And good morning, everyone. And I'm Dr. Ken Williams, and I'm chair of the Department of Medicine. And it is my distinct pleasure to introduce my really good friend, Dr. Dean Ornish, who is almost goes without introduction, but I'm going to do it anyway. Okay. And he's here giving our internal medicine grand rounds. We really appreciate the fact that he could take time to come and speak with us today. As I'm sure you're familiar with the name Dean Ornish because he is very famous in the area of cardiology and regression of the reversal of coronary artery disease. Today, he will be speaking about can lifestyle medicine often reverse the progression of early stage Alzheimer's disease. But a little bit more about my dear friend, Dr. Dean Ornish, who I just on the personal side have to say that I was influenced to go on a plant-based diet, largely by his work through someone I'm not sure, Dean, I know you've heard this story, but whether or not you actually met him. He's a leader at the Association of Black Cardiologists. Taswell Banks ran the CCU at DC General before that hospital closed. And he was always pushing the Ornish diet. This is the way to stop all the coronary disease. This is what I do for all the heart attack patients. I was always impressed with that and never paid too much attention to it until I found out that I had a real high cholesterol and went seeking the literature, saw plaque regression as well as risk factor reduction, and have to thank personally Dr. Dean Ornish. I know we've discussed this many times on the effect that it's had on me and ultimately my career, not just health. Dr. Dean Ornish comes to us. He was a Texas Longhorn for his undergraduate education, became a Baylor Bear for medicine. And then he transitioned to the Harvard system for as a internal medicine residence and clinical fellow. He actually was at the Mass General as well. And as you look at the number of research fellowships, you start to understand how he got to be the very elevated clinical researcher that he is. He has multiple academic appointments, including a clinical professorship at UCSF, and he has had multiple honors, summa cum laude, Phi Beta Kappa, Omicron Delta Kappa, and it really goes on. But the most important part of Dr. Ornish is that he has been a staunch advocate for prevention, and he has set up lifestyle medicine improvements that are so robust and really working on all the things that we need to help our patients to the point that people say that his program is so good that it's probably not about the diet because he does so many other wonderful things in terms of making sure that people understand the importance of social connection and love and smoking cessation, and all of the principles of lifestyle medicine are really aggregated in the Dean Ornish program. And so I just want to thank you as we start off with your leadership, for all your leadership over the decades. And we'll turn it over to you to hear more about early stage Alzheimer's disease. First time we've seen that have actually been reversal, not just stopping progress of the disease.
Thank you, Dr. Williams, for your kind introduction. Oh, excuse me. It's still early here. My voice is still waking up. I'm going to kind of do a survey of the work that we've done in heart disease before doing the work on Alzheimer's, because they share the same biological mechanisms. What's good for your heart is good for your brain, and I'll talk more about that. So let me share my screen here and see if I can get this going. There we go. So I want to present what I would call a unified theory of lifestyle medicine. Lifestyle medicine is a field that I helped create with Dr. Williams and others that uses lifestyle changes not only to prevent disease, but to treat and often reverse it. Pardon me. And the program that we've studied for now the 47 years has these four main modalities. It's a whole foods plant-based diet that's naturally low in fat and sugar and refined carbs, meditation and other yoga-based stress management techniques, moderate exercise, and support groups. Can you hear me okay? I just want to make sure you can hear and see everything.
Working perfectly.
Yay, great. Love when things work. Um, One of my favorite quotes is attributed to Albert Einstein. If you can't explain it simply, you don't understand it well enough. So to reduce the lifestyle changes to their essence is to eat well, move more, stress less, and love more. That's it. And the more studies we do, the more scientific evidence we have to show how powerful these simple changes can be and how dynamic they are. In other words, how quickly you can get better or worse depending on what you're doing. I think our unique contribution, as Kim mentioned, is to use these very high-tech, expensive, state-of-the-art scientific measures to prove how powerful these very low-tech and low-cost and interventions can be. We often think, people think, oh, diet and lifestyle, that's kind of boring. How powerful could that be? It has to be something new, a new drug or laser or device or surgical procedure to be powerful. And yet, as I'll share with you, these lifestyle changes can be, in some cases, as powerful or even more powerful. And often there's a synergy in combining them with drugs and surgery when used appropriately. U.S. News and World Report has panels of experts that rate hospitals and medical schools and universities, and they've also been rating diets for many years. And they've rated what they call the Ornish diet as #1 for heart health from a panel of experts there. And as Kim mentioned, most people think about our work, they think about diet, and of course, diet's important, but the other aspects are important as well. And people say, okay, I get the diet and, exercise, okay, and meditation. What is this love more stuff? That's kind of weird. And it's in many ways, it's one of the most important interventions. The real epidemics are not just heart disease and diabetes and Alzheimer's, but loneliness and depression and isolation, with the breakdown of the social networks that used to give people a sense of love and connection and community. 50 years ago, people had an extended family they saw regularly, a neighborhood with 2 or 3 generations of people who lived together, a church or club or synagogue or something that they went to on a regular basis, or a job that felt secure that they spent at least 10 years at and got to know their coworkers. And many people today don't have any of those things. And social media really is not an authentic form of intimacy. It's why one of the studies that I cite in my newest book says that the more time you spend on Facebook, the more depressed you are, because in a true intimacy, when you grow up in a neighborhood or you spend time with an extended family, they know you. They don't just know the wonderful things that are in your Facebook profile or the kinds of things that Kim said when he introduced me. They know your demons and your dark stuff, and the time you got busted or the time you broke that window or whatever it is, and you know that they know, and they know that you know that they know. And there's just something very profound and primal about being seen so fully and accepted, warts and all. And so part of our program is to create support groups that are not just to help people stay on the diet and to exercise, but also to create a safe place where people can talk authentically and openly about what's really going on in their lives without fear that they're going to be judged or criticized or given glib advice or rejected. And study after study has shown that people who are lonely and depressed and isolated are 3 to 10 times more likely to get sick and die prematurely than those who have a sense of love and connection and community. But anything that brings us together is really healing. Even the word healing comes from the root to make whole. Yoga is from the Sanskrit to yoke, to unite, union. These are really old ideas that were rediscovered. And the unifying theory is that, why is it that these same lifestyle changes can not only prevent, but often reverse the progression of so many of the most common and costly chronic diseases? And the answer is that they're not really as different as when I was trained. We were taught, different diseases, different diagnoses, different treatments. And yes, and of course, with all the interest in personalized medicine, how is it that these same lifestyle changes can have so many profound and far-reaching impacts? And the reason is that they share the same sorts of underlying biological mechanisms that I described in the Undo It book, which you can see Dr. Williams' quote is on the cover there. And the idea is that there are shared biological mechanisms among most chronic diseases, things like chronic inflammation, overstimulation of the sympathetic nervous system, changes in the microbiome and oxidative stress, apoptosis, angiogenesis, gene expression, telomeres, immune function, and so on, which affect all of these different diseases that are outlined in the right box. And they're all influenced, for better and for worse, depending on what you eat, how you respond to stress, how much exercise or not, and how much love and intimacy you have in your life. And so it radically simplifies what we tell our patients. We don't have to say, here's your type 2 diabetes diet, and here's your heart disease diet, and here's your Alzheimer's diet, and here's your prostate cancer diet, and so on. It's really the same recommendations. Of course, there can be some personalization. Some people are more efficient at metabolizing dietary fat and cholesterol or refined carbohydrates than others. But overall, these general same principles apply to each of these different diseases, because they all affect these underlying biological mechanisms. I had this cartoon drawn many years ago that I was doing my core surgery medical rotation with Michael Dept, the heart surgeon, when I was at Baylor College of Medicine. And, we cut people open, we bypass their clogged arteries. He'd tell them they were cured. And more often than not, they would go home and do the same things that had caused the problem in the first place. Eat junk food, smoke cigarettes, not manage stress, not exercise, and so on. And all too often, their grafts would reocclude, and we'd have to do redos over, sometimes multiple times. And a little like mopping up the floor without also turning off the faucet. Now, sometimes you do need to mop up the floor. Drugs and surgery obviously can be life-saving when used appropriately, but they don't really, in most cases, address the underlying causes of the problem. And that's where I think the lifestyle changes can come in. But by the way, I got a call from Dr. DeBakey about 4 or 5 years ago. He was really an old school tyrant back then. He was the kind of person that would stick you with a needle if you didn't move your hands fast enough out of the operating field. And I remember him saying, "What year are you, son?" I said, "I'm starting my 3rd year." He goes, "Damn, it's going to be so much harder to bust you out of here with all these weird ideas you have." And somehow I made it through the rotation. And then he called me about 4 or 5 years ago. And he said, "Hey, Dean, this is Mike DeBakey." He had this very distinctive Louisiana accent that I recognized after all these years. I said, "To what do I owe this honor?" He said, "Well, those weird ideas I used to give you such a hard time about when you were my medical student?" I said, "Yeah, I remember really well." He goes, "That's what's kept me alive all these years." He says, "I'm 99 years old. I'll be dead soon. I just thought you'd like to know that my wife got interested in your work and it really helped me." So if you live long enough, things sometimes come full circle. And part of what we've learned, and that continues to amaze me even after all these decades, is that if we can treat the cause, if we turn off the faucet, if we make big enough lifestyle changes, that our bodies often have a remarkable capacity to begin healing, and much more quickly than we had once realized, if we can stop doing what's causing the problem. So let me take you kind of through very quickly 45 years of work, and then use that as the context for talking about our latest findings on Alzheimer's disease, because Alzheimer's also shares many of these same underlying biological mechanisms, which is why what's good for your heart is good for your brain. So the first study I did, I decided to take a year off between my 2nd and 3rd years of medical school. I did a pilot study of 10 patients, and 8 of the 10 showed improvement in what was then a new test in their myocardial perfusion using thallium scans. And you can see here's a representative patient. As you know, the brighter it is, the more blood it's getting. And you can see in the left picture, the before picture, around 10 o'clock, it's dark in this donut. On the right, a month later, it's getting a lot more blood. And at the time, that was thought impossible, that once you had heart disease, the way people view Alzheimer's today is the way they viewed heart disease then, which is that the best you could hope for was to slow down the rate at which you got worse. But we found if you make big enough changes in lifestyle and change several things at the same time, that people could often get better. And it was especially surprising to show it in only a month, because at that time, the major mechanism that was thought to affect blood flow to the heart was the plaque in the arteries. And the idea that that could reverse over any period of time, but especially in only a month, was thought that can't be true. We now know that there's a web of interactions and mechanisms biologically that affect perfusion. The plaque is just one of many mechanisms. There's collaterals that can grow, preload and afterload factors, changes in platelet aggregation and blood viscosity, and so on. But anyway, it was also my first understanding that when you're doing something that doesn't fit within the conventional beliefs, that it's often met with a lot of resistance, which is appropriate in some ways because medicine is inherently conservative. But it was at a level like, well, you didn't have a randomized control group. How do you know they wouldn't have gotten better anyway? Well, that's true, but how often do you see patients get better like this? Well, that's beside the point. Or you didn't control for the time of day, or so on. So anyway, went back to school, finished my MD, then did a second study. This time we did have a randomized control group for comparison. And we used radionuclide ventriculography to look at the ejection fraction response from rest to peak exercise. And normally that should go up. Your heart not only beats faster, but stronger as you exercise. The percentage of blood that's ejected with each beat should go up, as well as the heart rate. But in someone who's got, pardon me, extensive coronary disease, the supply-demand ratio may come off, and so the blood can't keep up with the demand. And so paradoxically, the ejection fraction may fall from rest to peak exercise. And that's what happened with these patients. All of them, their ejection fraction fell from rest to peak exercise pre-intervention, but in the intervention group, it rose appropriately But in the control group, it fell even more after just 24 days. And we published that in JAMA. We also found in both studies that most of the patients became angina-free during that time, which is a powerful motivator, which I'll talk more about. Went to Boston, did my medical residency and fellowship, moved to San Francisco, joined the faculty at UCSF, started the nonprofit Preventive Medicine Research Institute, and began the most definitive study called the Lifestyle Heart Trial. And we used quantitative arteriography to look at stenosis and cardiac PET scans to look at changes in blood flow. We actually flew our patients to the University of Texas, which had at the time the best cardiac PET scanner. So we went to a lot of trouble to try to do this with the state-of-the-art measures. These were all blindly analyzed with independent observers. And you can see that, excuse me, sorry, my voice is still waking up here, that the percent diameter stenosis was about the same in both groups pre-intervention. Everyone had at least one lesion that was 75% or greater. Most of them had more extensive disease. And you can see in the red line that patients in the randomized control group who were on the American Heart Association and NCEP Step 2 diet, their arteries got more clogged after 1 year and even more clogged after 5 years in the red line. The intervention group, there's some regression overall after 1 year, which was significant, which we published in the Lancet, and then even more regression after 5 years, which we published in JAMA. There was a fourfold improvement in myocardial perfusion as measured by cardiac PET scans using N13 ammonia or rubidium-82 after 5 years, which we published as a separate paper in JAMA. This is a representative patient showing what regression looks like. This is an angiogram quantitatively enhanced, and you can see where the arrow is in the upper left. The stenosis is outlined, and you can see on the right a year later that it's less clogged. And as you know, perfusion is a fourth power function of the radius of the artery. So even moderate improvements or increases in stenosis can cause exponential improvements in perfusion. And that's what we measured in the PET scan in this patient. You can see that in the lower left, pre-intervention, blue and black is no perfusion. In the lower right, a year later, orange and white is maximal perfusion. And this wasn't best case. This is fairly representative of what we found. And as evidence of that, 99% of the patients stopped to reverse the progression of their heart disease. Again, these were all blindly read by independent observers after 5 years, whereas only 5% of the randomized control group patients got better. One of the interesting findings is we came up with an adherence formula that took into account all four aspects of the lifestyle intervention. And despite the limitations of self-reported data and the kind of crudeness of the formula, we found a dose-response correlation between the degree of change in lifestyle across both groups and the degree of change in coronary artery stenosis. And we found this using the same formula in every study that we've done, which I'll talk more about. The more you change, the more you improve. Now, I had thought incorrectly, as it turned out, that the younger people who had milder disease would do better, but it turned out that wasn't true. That the primary determinant of improvement wasn't age or disease severity, it was the degree of lifestyle change. And there were 2.5 times as many cardiac events in the control group as in the experimental group: heart attacks, strokes, bypasses, angioplasty, stents, and so on. And to put a human face on this, I'm going to show you just a 1.5 minute testimonial from a guy who's a doctor, who's an internist himself, who had such a massive MI that his ejection fraction was down between 11 and 15%, and was told that only a heart transplant could keep him alive. And while looking for a donor, he went through our program at UCLA to get in better shape for the heart transplant. And his ejection fraction improved to more than 30% in just 9 weeks, to the point he didn't need a heart transplant anymore. And I show this because, you know, what's the more radical intervention here? You know, changing lifestyle or getting a new heart? It saves over $1 million and a lifetime of immunosuppressive drugs, but it's also, I think, an indication, again, of how powerful these simple lifestyle changes can be. So let me play this for you.
So the situation I'm describing here is of an internal medicine doctor who started a new chapter in his life with his wife, moving to Lake Arrowhead, having just opened a private practice office after all of our kids went to college and we could relocate. And just as this was ramping up, we had a horrible car accident which precipitated a heart attack that dropped my cardiac functioning down to basically 11 to 13 or 14, 15% of what it should have been, which resulted in intractable chest pain, angina, trouble breathing, inability to walk from room to room, go upstairs without being carried. was offered a heart transplant as the only way to stay alive. And at the 11th hour, I entered the Ornish program, which provided me with an entire paradigm shift with respect to stress management, exercise, diet, nutrition. And despite not believing it myself and having other physicians who didn't believe in it either, it worked beyond my wildest dreams. I'm now able to exercise moderately. I can work full time. I can live at 6,000 feet. And our quality of life is actually better than it was before.
I love stories like this. And to put this in a larger context of the health crisis that we're dealing with, as you know, we spent $4 trillion last year in this country on healthcare, which is mostly sick care. And the vast majority of that, 86%, was for chronic diseases, which can often be prevented or even reversed by making these lifestyle changes. So if we really want to lower healthcare costs, we need to turn off the faucet, if you will. And it also is true that 5% of the population accounts for a disproportionate amount of these healthcare costs, 50 to 80%, for example, and heart disease is number one among them. So if we can prevent or reverse heart disease, then we can also reduce healthcare costs in ways that don't involve rationing or cutting back on services. We've done 2 demonstration projects to look at whether this is medically effective, cost effective as well as medically effective. And we've done 2 demonstration projects. I love this cartoon. It says, I can operate or you can go on a strict diet. He says, you better operate. My insurance doesn't cover a strict diet. And so the first one was done with Mutual of Omaha. And they offered in people who were scheduled for revascularization with their doctor's permission when they were stable, they were said, you can have a stent or a bypass, or you can make these lifestyle changes. And almost 80% of the people chose our program as a direct alternative to revascularization, did equally well. And Mutual of Omaha found that they saved almost $30,000 per patient because it's a lot cheaper to change lifestyle than it is to undergo surgery. We did a second study with Highmark Blue Cross Blue Shield of Western Pennsylvania, Nebraska, and what am I leaving out here? Nebraska, West Virginia, and Delaware. And their head of medical informatics, Don Fedoroff, was very skeptical of this, which I always welcome because then whatever you find is credible. And compared to a cohort of patients matched for age and gender and disease severity, the costs were at essentially the same at baseline. But costs were cut in half in the first year. And even though the program was only 9 weeks long, even 3 years later, they're still showing cost savings because most of the patients find that they create such tight bonds from the support groups that they continue to meet on their own, sometimes for decades, at no additional cost to anyone. So they can maintain the lifestyle changes. And when they looked at a subgroup of people that they'd spent at least $25,000 or more on in the previous year, there was a 4-fold reduction in costs. And this was across the board, from reduced ER visits, length of stay, hospitalizations, procedures, medication requirements, and so on. I thought, it's great that Highmark, Blue Cross Blue Shield, and Mutual of Omaha, and some others were covering our program, but I thought if Medicare would cover it, that would really be a game changer. I had no idea it would take 16 years to achieve that, but it was worth it because when you change reimbursement, you change medical practice and even medical education. And so in 2011, CMS created a new Medicare benefit called intensive cardiac rehabilitation, which we've been offering. This was the decision memo after 16 years. And they've been covering it virtually, by the way, since COVID hit. If anything good came out of COVID, it was learning that we could do this virtually as well as doing it in person. And that opened up a whole new world. That also helped reduce health disparities and health inequities because a lot of people can't go to the hospital because they can't afford to take off work, or they can't get childcare, or they don't have transportation, or they can't afford parking, or they don't want to get exposed to COVID in the hospital or whatever. So now people can do it from the comfort of their own home, and they don't have to live near one of the hospitals or clinics we train. So anybody can really do it, and Medicare will cover it. And by the way, if you have any patients who are interested in learning more about our program, just go to ornish.com, and Medicare and Aetna and many of the Blue Cross Blue Shield programs are covering the costs of it. We then wondered if these same lifestyle changes might affect the progression of early stage prostate cancer. And we did this in collaboration with the chair of urology at UCSF, where I'm a full professor, Peter Carroll, and the then chair of urology at Sloan Kettering, Bill Fair, who unfortunately has passed since then. We always try to work with the top people in the field because when you're doing something new, it makes it easier to get published. And we took men who had biopsy-proven prostate cancer who had decided to do watchful waiting, or now called active surveillance, for reasons unrelated to the study. And so from a design standpoint, that allowed us to, pardon me, to have a non-intervention control group for comparison, which you can't really do with most forms of cancer because people usually get treated right away. And you can see the PSA levels went up in the intervention group, they went down or got better in the, they went up in the control group and got worse. They went down in the intervention group, got better. The differences were highly significant. Published that in the leading peer-reviewed urology journal. And again, we found a dose-response correlation between the degree of lifestyle change and the degree of change in their PSA levels. The more people changed, the lower their PSA levels went. But PSA is an imperfect measure of prostate cancer, as you know. So we added some of their serum to a standard line of LNCAP prostate cancer cells growing in vitro in tissue culture in Bill Aronson's lab at UCLA. And the tumor growth was inhibited by 70% in the intervention group, hardly at all in the control group, in direct proportion to the degree of lifestyle change. That was really kind of mind-boggling to me, that the more people changed their lifestyle, it actually created something in their blood that when they added that to a standard line of prostate tumor cells growing in tissue culture, inhibited the growth of the tumor in direct proportion to the degree of lifestyle change across both groups. And we did MR spectroscopy on a subset of patients and found that the tumor activity, as seen in this patient, was diminishing, shown in red, as well as the PSA levels coming down. And none of the experimental group patients needed surgery or radiation or brachytherapy during the year of the intervention, but 6 of the control group patients did. We then wondered what some of the mechanisms might be to help explain that. So with Craig Venter did gene analyses, and we found that gene expression was changed in over 500 genes in just 3 months. And in fact, upregulating the genes that are protective, and particularly downregulating the genes that are part of this unifying theory that I mentioned earlier, downregulating genes that are linked with chronic inflammation, oxidative stress, et cetera, which provides now a plausible biological mechanism, or one of the mechanisms at least, but why which lifestyle changes can cause these improvements. We also found that the RAS oncogenes that promote prostate, breast, and colon cancer were downregulated. And you can see on the right column are different oncogenes. Red pre-intervention is turned on, green post-intervention is turned off. So again, 3 months, we can change so many gene expressions. You're not actually changing the gene, but you're changing the switches that turn these genes off and on. You know, the methylation, the sirtuins, the histone and non-histone proteins, and so on. But functionally, if you can turn off a gene, it's as though you're changing the gene. And I'm sure you've had patients tell you things like, oh, it's all in my genes, there's nothing I can do about it. Well, actually there is. Again, not to blame patients, but to empower them, because if it's all in your genes, then, you know, what can you do, right? But it turns out we can do a lot, and how quickly and how impactful these lifestyle changes can be on gene expression. We then did a study with Elizabeth Blackburn, who got the Nobel Prize for for discovering telomerase and telomeres, the ends of our chromosomes that regulate cellular aging. And as DNA replicates, the telomeres over time get shorter. And as our telomeres get shorter, our lives get shorter, and the risk of premature death from all of these different chronic diseases that we've been talking about, including Alzheimer's, goes up proportionate to that. We found that when people she had done studies earlier with Alyssa Epple, that people who smoked and were sedentary and who were under chronic stress and ate junk food, their telomeres got shorter faster. So I met with Dr. Blackburn and I said, you know, if bad things make them shorter, maybe good things make them longer. And we found, sure enough, that in just 3 months, the telomerase increased by 30%, which we published in the Lancet Oncology. And over a 5-year period, we found for the first time that any intervention, in this case, these same lifestyle changes, could actually lengthen telomeres. And when we published this, the Lancet editor sent out this press release calling it the first study showing that positive lifestyle changes may reverse aging on a cellular level. As I'm getting older, that has more meaning for me now than it did even when we published it. And again, we found that there was a dose-response correlation between the degree of lifestyle change and the degree of telomere lengthening. So that's kind of the larger context for what I want to focus on now, which is our most recent study that we published a few months ago, showing for the first time that any intervention could in effect stop or reverse the progression of early stage Alzheimer's disease in the majority of patients. This was, as I mentioned, where to stay with Alzheimer's, very similar to what people were saying 45 years ago when I started doing research on heart disease. Back then, they'd say, you know, the best you can do is slow down the rate at which heart disease gets worse. We found for the first time that if you make bigger changes in a lot of things, that you can often get better and better instead of worse and worse. And we're finding something now similar with Alzheimer's disease, which again shares many of the same biological mechanism, which is why what's good for your heart is good for your brain. So the specific aims were, can this multimodal intensive lifestyle change program, the same program, beneficially affect the progression of early stage Alzheimer's disease using 4 of the standard measures that are used in FDA drug trials? Was there a correlation between the degree of lifestyle change and the degree of improvement? And what happened to one of the primary biomarkers, especially what's called the A beta 42/40 ratio, which is a measure of amyloid. And as I'm sure you know, the amyloid hypothesis is that amyloid kind of gunks up your brain and is a primary mechanism along with tau that's causing dementia. So the drugs that have been approved for treating Alzheimer's work on the A beta 42/40 ratio. Excuse me. So these are men and women, pretty diverse. They all had early dementia due to Alzheimer's disease or MCI. The doctor, made sure the patient had the diagnosis, and there was a spouse or caregiver to support them. It was a randomized controlled trial for the first 20 weeks. We went to a lot of trouble to help them stay on it. This was again, we started meeting with them in person, and then when COVID hit, we started doing it virtually, and that opened up a whole new world for us because now we could collaborate with some of the leading scientists at places like Harvard and Mass General, where they would recruit and test the patients locally, but we would do the intervention by Zoom, and we would send them their food. We did it, and it's all been done by Zoom since March of 2020. We did it all at no cost to the participants, and because we thought if we could really get them to adhere to the intervention and it didn't show anything, that would be an important finding too. It'd be, sad, but people need to know if it's not going to work. But if they didn't follow it close to 100%, we knew that we really couldn't test the hypothesis because, pardon me, the reason that we were the first to prove you could reverse these other conditions is that it's hard. You have to make really big changes. It's the pound of cure as opposed to the ounce of prevention. And so we gave them, all the patients and their spouse or caregiver, all of their meals and snacks for the entire 20 weeks. So that we said basically just eat the food that we give you so we could test our hypothesis. It's a multimodal intervention. It has a doctor, a nurse, a meditation teacher, exercise physiologist, dietitian, and psychologist. Same as with the heart disease intervention. And it's 4 hours, 3 times a week for the 20 weeks. And they got an hour of exercise, stress management, a support group, and a lecture. We also gave them some supplements. Pardon me. Sorry, my voice is still waking up here. The omega-3 fatty acids, a multivitamin, CoQ10, vitamin C's, B12, magnesium, lion's mane, and a probiotic. We use 4 of the primary endpoint measures that are used in many of the FDA drug trials, the ADAS-Cog, the CDR Sum of Boxes, the CDR Global, and the Clinical Global Impression of Change. We also did the inflammatory and the amyloid biomarkers were done at Mass General and Harvard with Rudy Tanzi and Stephen Arnold. Telomere link was done in Dr. Blackburn's lab. The microbiome studies were done in Rob Knight's lab, who's considered the leading microbiome expert in the country. And the metabolomics were done at Duke at Rima Kadura-Duke's lab. This is just the consort flowchart. We ended up with 51 patients. There were no significant baseline differences in any measures. This was the study we published in May in the leading, this was the only journal we submitted to. It's the leading translational Alzheimer's research journal called Alzheimer's Research and Therapy. Now, the CDR Global, lower is better here. So you can see that in the control group shown on the left got worse. The intervention group shown on the right got better. These differences were highly statistically significant. The ADAS-Cog, again, same pattern, worse in the intervention in the control group, better in the intervention group. The one measure that was essentially slightly worse, essentially unchanged in the intervention group, but much worse in the control group was the CDR Sum of Boxes. And the 4th test, which I think is actually the most clinically relevant, is called the Clinical Global Impression of Change. And why I like is that they not only interview the patient, but also their spouse or caregiver. And they really, nobody knows how the patient's doing better than the spouse or caregiver because they're with them all the time. And so we found that in that test, 71% of the patients in the intervention group stopped or reversed the progression of their disease, whereas none of the patients in the randomized control group got better and 68% got worse. We also found statistically significant correlations between, again, the degree of lifestyle change and the degree of change in all 4 of these measures. The more people changed, the more they improved. Now, how much change did they have to make? We said, where do these lines cross? And it turned out for the ADAS-Cog, they needed to adhere at least 71% or better to stop or improve. With the CDR Sum of Boxes, it was 120%. And the CDR Global, it was about 95%. So here again, this is not so specific, but it shows pretty clearly that you have to make really big changes to reverse the progression of these diseases. Now, the plasma A-beta 42/40 ratio, there were only 3 drugs that have been approved in the last 20 years. And billions of dollars have been spent on drug development. And the 3 drugs that have been approved are aducanumab, lecanemab, and donanemab. And all 3 work by, in effect, pulling amyloid out of your brain is kind of a simple way to put it. And what they measure is what's called the A-beta 42/40 ratio, which is a measure of amyloid. So the drugs work by pulling the amyloid out of your brain, so the blood levels go up, which means that it's going up in your blood because it's coming out of your brain. We found the same pattern from the lifestyle changes that are found with the drug trials. We also, but with the drugs, first of all, they're very expensive. They're like $30,000 plus per year, plus infusion costs and other tests that have to be done. A significant number of people develop bleeding in their brain, brain swelling, what's called ARIA, and I think it's because you're kind of pulling it out of your brain. We didn't find that in our patients because it's more gentle, if you will, because it's done through lifestyle changes. And even then, all 3 drug trials just show that they slow the rate of getting worse. But getting worse more slowly is still getting worse. And so the suicide rate within the first couple of months after being diagnosed with Alzheimer's is 7 times higher than the general population because they take your hope away. And they say, it's only going to get worse, get your affairs in order. Best we can slow it down a little bit. And really, it's imperceptible for many people. And it works better in men than women, even though twice as many women as men get Alzheimer's disease. And it's really, in many cases, contraindicated in people who are homozygous for the ApoE4 gene. And yet we found the lifestyle changes work just as well in those who are homozygous as those who just had one, who are heterozygous. We also found that insulin levels decreased significantly. Beta hydroxybutyrate ketones increased. So because it was not a intentionally ketotic diet, but it was a low carb diet in the sense that it was fruits, vegetables, whole grains, legumes as they come in nature. We excluded concentrated sweeteners and refined carbs like white flour and white rice and sugar and things like that. So we got the benefits of a ketotic diet without the toxicities of substituting meat for carbs. Pardon me. We also found that glyca, a measure of inflammation, decreased 8 times more in the intervention group. We also found statistically significant correlations between the degree of lifestyle change and the degree of changes in the A-beta 42/40 ratio, which gives it that much more biological plausibility. In other words, the more you change your lifestyle, the more effective it is at pulling amyloid out of your brain. Now, as I mentioned about the 3 drugs, we've actually already talked about this, got ahead of myself. And the reason why I think the lifestyle changes stop or even reverse the progression of Alzheimer's, whereas the drugs just slow it down, excuse me, I'm so sorry, is that the drugs are just focusing on one mechanism, the amyloid, the A-beta 42/40 ratio, whereas the lifestyle changes affect that, but also all these other mechanisms that we've been talking about, chronic inflammation, oxidative stress, and so on, that underlie this unifying theory that I mentioned earlier. We also found changes in the microbiome, the 100 trillion cells in our gut, and some people think that the amyloid actually begins in your gut. And we found that, in simple terms, the organisms that are protective went up in the intervention group and down in the control group. The interventions that were harmful went down in the intervention group and up in the control group. So that's just another mechanism by which these lifestyle changes may be so beneficial. So in conclusion, we found that comprehensive lifestyle changes may improve cognition and function in several standard measures after 20 weeks, whereas in the control group, all 4 measures got worse. The validity of these findings was supported by changes in the plasma biomarkers and the microbiome, the dose-response correlation of the degree of lifestyle change with the degree of improvement in all 4 measures of cognition and function, and the correlation between the degree of lifestyle change and the degree of change in the A-beta 42/40 ratio, as well as these other biomarkers in a beneficial direction. I think there are implications here for preventing Alzheimer's disease as well. Excuse me. There are new AI-enhanced technologies for picking up Alzheimer's disease up to 10 years before it becomes clinically apparent. But a lot of people say, why would I want to know? And a lot of people don't even want to get their ApoE4 test to say, why would I want to know if I'm more likely to get this horrible disease if I can't do anything about it? It'll just make me crazy. But now that we've shown that we can often stop or reverse its progression, then the implications for its progression, the implications for prevention, I think, are even more profound, because as the population ages, this is going to be $1 trillion for not to mention the tragic. I mean, my mom died of Alzheimer's. I've seen firsthand how terrible it can be, and she was a true genius. And all of her siblings got it. I have one of the ApoE4 genes myself, so I have a particular interest in this. But like, ounce of prevention, pound of cure. If you know 10 years earlier that you're likely to get it, or if you find you have one of the ApoE4 genes like I do, that can be a great motivator for not saying, oh gosh, woe is me, but now I'm going to start making these changes. And you probably don't have to make such big changes to prevent Alzheimer's as you do to stop or reverse it, just like we found with other diseases like heart disease. And so, and everybody agrees that the earlier you intervene with Alzheimer's, the more likely it is that it's going to be beneficial. Now, we still, we've raised a lot of questions. We need longer follow-up. We want to look at more diverse populations, why some people respond better than others, other than the degree of lifestyle change, and the potential synergy of lifestyle changes and drug therapies, much as we find, for example, many patients do statins and lifestyle changes and get better effects than they could with either alone. I want to just end by showing you a couple of patients talking about their improvements. It's easy to dismiss stories as being anecdotal and not scientific, but stories are powerful. And if you have the scientific data, the stories can really give an indication of what does that really mean? Okay, it's statistically significant, but what does it really mean clinically? So this is a guy, excuse me, who was, CFO of a major company, was diagnosed with Alzheimer's disease, and his wife talking about what their experience has been. Let me just play this for you. And by the way, he's homozygous for the ApoE4 gene.
And then you went to the doctor, and what did the doctor tell you?
Well, the doctor gave the statement that that I had Alzheimer's, and kind of more of a negative approach to it, I think. He wasn't positive at all in terms of what I could see, or do in the future.
It was very difficult. I mean, it's a horrible diagnosis to receive for anyone, because as of today, there's no cure. There's nothing really that anybody could do to help you. And I remember clearly the neurologist saying, if there's anything you'd like to do it in the next couple of years, and get your life in order, get your finances in order, make plans, because you've only got a couple of good years left. So it's devastating.
And that there's nothing they could do to change that.
Exactly. There's the pill you take that maybe will slow things down, but other than that, take the best care of yourself you can, and that's it. So being part of this study has changed that for us totally. It has given hope. We've seen positive results, and whether that lasts for years or whether it's only for a short while, it's giving us a lot of hope, and hopefully will expand that 2-year time frame that the doctor gave us. We're well past that now, so there's a lot to be hopeful for with this study.
As you mentioned before that you were doing a lot of CFO kind of work, chief financial officer work. And you weren't able to do that, and you weren't able to do your household finances either, I presume. Is that right?
Correct.
But now, tell me what's changed in that regard.
I'm back to reconciling our finances on a monthly basis. I keep up to date with our the investments and any changes that need to take place with that.
Is that a change from a year ago, where you can do things now that you couldn't do a year ago?
Yes. Well, it's kind of like doing a happy dance. Because it's so much a part of my life, and who I am and was. It's kind of hard, saying that part of me was just gone, and so I just it's a lot of self-worth that comes back.
Good. And then you mentioned before that before you weren't able to read because you kept forgetting what you'd read and you'd have to start over and you get frustrated and said to hell with it. How has that changed?
I'd say several years ago, Mike quit reading. It just wasn't worth it to him. He would forget what he read. He'd have to start over. He's always loved reading lots of books. He traveled a lot and he was always reading on airplanes. Reading was just important and a positive experience. And then he quit because he couldn't remember. So just in the last, I would say about 4 months, he's reading again.
Before it would take me weeks to finish a book. And now I'm able to pick up a book and to read and to remember what I've read and be able to finish that book within 3 to 4 days.
Here's a woman who, pardon me, is also homozygous for the ApoE4 gene, talking about her experiences.
What have you noticed in terms of your cognitive function or any other things that you've been looking at?
Well, I'm starting to read more. I had lost that ability. I love to read. I'd be the kind of person who would pick up a book and I don't care how big it was. I would not put it down. I'd not go to sleep at night because I had to finish that book. So I'm not reading to that degree, but I am starting to read, and I've chosen to start with a smaller book so that I can feel that accomplishment a little bit earlier for me.
And you stopped reading because why?
I could not retain the information. I would forget who the characters were. I'd forget what order things were going in, and it just got to be one, humiliating for me, but it just became too difficult. So I thought, I'm just not going to do that. I gave up the cooking for a long time and doing those kind of things. And so that has started to come back.
How long did it take before you started to notice improvements?
Oh, good question. I'd say in the scheme of things, relatively quick.
Yes.
I mean, given I'd been on Aricept for so long, I didn't see any changes with the Aricept.
Right.
So this was.
We'd say around week 12 would
Okay.
be a
Yeah.
good estimate.
Probably.
Yeah. And you mentioned before also you're able to do your taxes.
Yes.
Tell me about that.
Oh, yeah. In fact, so we've got several small businesses, property management, and I used to do all the books for that and then obviously didn't. And then this year I said, would you like some help? And he says, yeah, here's this stack of stuff that we need to go through. So I organized it all, put it all into piles with pieces of paper on headers so I could hand it to him. But then I took it a step farther and unbeknownst to him, I created spreadsheets. They're all color coordinated. It has a face sheet on it that says, this is what we earned. This is what we spent. Here's our net. This is our whatever's all written out. And said, here you go. It's all done.
It was astonishing.
Why?
Well, for one, I didn't have that expectation. I had the expectation of, just go assemble these in some sort of an order so then I can go back and take care of it. But when she came back to me, they were not only all categorized in a proper order, beneficial order, more importantly, they were all done correctly.
Yeah.
And for me and for Tammy, it was like
Yeah.
absolute jubilation. I
It
mean, it
was.
was exciting. Do you realize what you just accomplished was such a remarkable
Down to using the calculator, which I hadn't any. Because, well, I'm going to check your math even with the calculator. I said, calculator's not going to lie, but go ahead, and his numbers matched mine.
Wow.
I'm like, yay.
No,
Yeah.
my numbers missed yours.
That's true. That's true.
Now, was that something that you couldn't have done a year ago?
Oh, yeah, for sure. Yeah, I don't think it's been 4 or 5 years probably that I've really gotten involved to that degree.
What might have happened?
Well, I would get really frustrated with myself, and then I'd get the paperwork all mixed up and I'd put them in the wrong pile, or I wouldn't add it up properly. And it became so confusing. I just hand him this jumble of papers essentially and say, I did the best I could. Good luck.
So how does it feel to be able to do things that you didn't think you'd be able to do before? How does that make you feel about yourself?
I think that deep sense of identity is returning. It's given me like a new lease on life, and yet it's a familiarity and something that I always prided myself in. And so it's like, yes, I'm coming back. It was really good.
You're coming back like
I was prior to the disease being diagnosed.
yeah, one of the other study participants said, I feel like I'm me again. Does that sound familiar?
Absolutely. That's a great way of putting it. Yeah, an older but better version of me. Yeah, I really feel that way.
All right, so let me stop here. I've covered a lot of stuff, as you can see, but I'd like to have at least a little time for questions. If anybody has any questions or comments, I'd welcome them.
So thank you so much, Dr. Ornish. This was a real treat to go through the effects that lifestyle can make, and particularly with nutrition and the multifaceted lifestyle changes that you've been promoting for so many years. So we got a little cardiology, we got some oncology, and now some neuropsych. The chair always gets to ask the first question, so I'm going to go ahead and just hearkening back to your initiation of really objectifying change with nuclear cardiology. The question is, have you looked at any of the newer agents, or are you planning to, particularly for neuropet? So there's fluorine 18 fluorobetapir for amyloid, and there is the tau protein can actually be imaged with fluorotaucipir, fluorine 18. And just wondering if there's a chance to have you display these differences that you've shown so clearly back in the day with cardiology with the modern nuclear medicine approaches.
Yeah, well, that would be an interesting study to do for sure. We didn't have the resources to pay for that, and they weren't really available when we started the study 6 years ago. Pardon me. But some of the newer technologies like C2N and others are finding that measuring these, tau 217 and the A beta 42/40 ratio in the blood plasma is highly correlated with what they're finding on these imaging tests. So I think that can be really a good surrogate. And because we have some plasma frozen, we're also looking at, we follow these patients actually for a total of 40 weeks. We're on the basis now of looking at those and also looking at the p-tau 217, which we have the frozen plasma, so we'll be able to look at those markers as well.
Great. So invite anyone to unmute and speak up with your question. And we have Dr. Pathakji.
Yes. Hi, Dr. Ornish. As a former cardiologist, having listened to you and Dr. Ornish argue at ACC, it's a trip down the memory lane. My question is there any, because the amyloid is still a hypothesis, it's not a proven thing. So there are a lot of things that may be influencing, like glial cells. And so is there any plan to study the genomics type of thing, like the comparative genomics expression study that was done for cardiology? Because there is more than one gene, ApoE gene, that are involved in Alzheimer's. That's one question. And the second question is, how does your work compare with another work that is done by Dr. Bredesen at UCLA?
Right.
Okay, I'll shut up. Thank you.
Well, we didn't look at gene expression of these patients, although we did look at telomere length, and we did find that that there were changes in the groups, especially when we looked. One of the Alzheimer's Drug Discovery Foundation was one of the people that funded our study. They asked us to do an interim look midway, and we found that even midway there were significant lengthening of telomeres in the intervention group and shortening in the control group. By the time all the patients were analyzed, there was still lengthening in the intervention group, but the control group, instead of shortening, was essentially unchanged, because in the last couple of cohorts, some of the patients began making lifestyle changes more than what we would have liked. So, but we didn't look at the genomics. That would be a really interesting follow-up study to do. Dale Bredesen's work, he actually approached me. We were actually talking about doing a study together, and then I found that he was going to write and ended up writing a book, claiming that he could reverse Alzheimer's based on 10 patients in a pilot study. And I said, Dale, you can't do that. That's, this is a really serious thing, making a claim like that. And you have to, if you do a randomized trial and then you show that, then write a book. I always, but you can't, you're going to be ostracized and it's going to be, unethical to me to make a claim like that without having the science to support that. So our paths diverged because of that.
Yes. Thank you.
It was very interesting 10 years ago to see the hope, and then we didn't see any follow-up of the 10 patients, and it wasn't randomized, as you mentioned. So we have a question from Dr. Levinson. Thank you for a clear and informative talk. In the lifestyle Alzheimer's study, was there an association with BMI?
We didn't find that. But most of the patients weren't terribly overweight, but we didn't find that correlation.
I see. Okay. All right. And looking to see if there's other questions.
If I could just add one thing. I think
please.
Dr. Bredesen is doing really important work. I don't want to in any way disparage that. And he's continuing to do work, and now he's beginning to do those studies. But I just thought that, again, that those studies should be done before making claims in a book for the general public. But he's a brilliant guy and doing important work.
Understandable. And so what I remember about his program is that he shares some things, low carb or getting rid of refined carbohydrates was something that you both have done. Another one was your slide on the supplements, which I'm sure excited a lot of people because there are people who believe in each particular one, but you had actually a fair number of them. And so I would imagine that you'd get the people wondering, well, which are the most important? We went through the omega-3 fatty acid issue in cardiology and the Reduce-It trial, and it looked really good, but no, they actually did the comparator was not corn oil, but it was mineral oil. Therefore, it was invalid, and anything that's done with corn oil shows that the omega-3s don't actually help the heart. And we're still in a little bit of a quandary in the cardiology arena, but I know that was at the top of your list. Can you talk about the function of the supplements and how important they are, and whether or not they influence the results? And if you have any hints, obviously you didn't do a randomized trial of each individual one.
Yeah, well, they weren't in order of importance. They were just it was just more random the way they were listed. My approach in doing this study, and many of our studies, it's a common criticism throughout my career. Like, people say, well, to do good science, you have to have one independent variable, one dependent variable, keep everything else constant. When you do that with, say, the drugs for like lecanemab and others, it just slows down the rate at which you get worse, because changing one mechanism isn't enough to change the course of the disease. So our approach is to change a number of things at the same time. And we really can only speculate about the relative contribution of each component. But, pardon me, unlike the drugs, the side effects are generally good from changing your diet and exercising and meditating and loving more. With the supplements, we generally picked ones that we thought at best wouldn't be harmful, but you never know. But it's using the primum non nocere. If it's don't first do no harm, but if there's a chance it may help, and they're not very expensive, and there may be a potential synergy with the other lifestyle changes. If that helps us see a difference, then we can leave it to further studies down the road, which will become much easier to get funding for now that we've shown that at least in aggregate we can get this effect, to parse out what the relative contribution of each component is.
Well, thank you very much for that. Jason, I don't see any other.
Yeah, there actually was one question. I think it got kind of sandwiched in there. It's
Oh, please.
someone wants to know, is there any specific neurotropic factors to be considered to improve Alzheimer's disease patients' cognitive ability, like BDNF?
Well, we did find in other studies that BDNF increased, but we didn't measure a correlation with that in this study. Let me just say in closing how much I appreciate the opportunity, first of all, to see my friend Kim again, even virtually, to share these findings with you. At least I hope that some of them have been useful. I know we've raised as many questions as we've answered. If you have patients who are interested in either our cardiac or our Alzheimer's program, just go to ornish.com. Much of that, at least for the cardiac, is covered by Medicare and other insurance companies, and we hope eventually Medicare will begin to cover it for Alzheimer's as well. It's exactly the same intervention. They just need to broaden the inclusion criteria. So thank you so much for the chance to be here today.